First of all, thank you very much for the introduction and for Ceva to inviting me. As I said, I'm an applied biologist by training, so I work in the section of pediatrics at St Mary's Hospital in London, so that's slightly different. So just to put that in context. And so I've decided today to put the emphasis on point of care, because that's where a big market now, not so much in the veterinary, but getting there, and show you some of the new technologies and also talk about what's coming along, what's there, and also at the end, talk about some of our work with veterinary pathogens, and really to pose a question for you guys as well, is to make you think, I hope, by the end, as to where, if you were going to apply point of care technology, what are the type of considerations that you need to make, and to make you think a little bit about it, but also to get some feedback from you as to whether you think that what we're doing is worthwhile, or whether there might be a market for point of care for what we're doing. So that's really to pose some questions for you as well, and we would really appreciate your feedback on that. Okay, so I've just summed that up. So first of all, what is meant by point of care? That sounds very straightforward, but it's very clear when you look at the veterinary literature and compare it with the human literature. Actually, it means different things. So in the veterinary arena, is that point of care, about half the literature is to do with things like bioanalyzers. Yeah. So there you are, companion animals, you have a little lab next door, that is considered point of care. Whereas in the human area, is that actually then you're talking about, up here at the top, things like lateral flow devices, which I'll come to. And if you look at the literature, there is one hell of a lot of definitions. It's really hard to home in on a definition of what point of care means. I like this definition. This is from the College of American Pathologists. So, tests designed to be used at or near the site where the patient is located do not require permanent dedicated space and are performed outside the physical facilities of a clinical laboratory. That may be different depending on your situation. So if you're big pig producers, point of care to you may mean one little room away from the big production facility. In the UK, where there is a lot of animals which are raised outside, then that may mean something completely different. And I was talking to a vet a few weeks ago who works with outside pigs, who said, if you want to design something for point of care, design it so I can use it in the boot of my car. Yeah, and I actually quite like that. So there's a little space and that you can deal with that. Or it may mean to you a room nearby. So it may mean different things to you is my message. But what you've got to do is target what is the real situation. So this is a fairly obvious slide, really. So what are we trying to do with point of care? Well, we're trying to remove sending specimens away, etc., waiting 24 hours, 48 hours. Some of my colleagues complain that it can take weeks to get results back. So getting something there really quickly. And if you look at the literature, the sort of places where they say point of care could be useful are the ones which are on this side. So, invaluable tool, dealing with disease, represents a threat to public health. I'm not so sure about where laboratory facilities and funds are limited. I'm not so sure about that one. But the last one is maybe precedent at the moment, especially useful in disease outbreaks with rapid propagation of infectious agents and high mortality. So that could be African swine fever at the moment, and we'll come back for a test for that later. So, but can you use it? The question is also, can you use these tests in your normal practice? So for those of you that know the point of care literature, you will see this everywhere. So this is some criteria that the WHO have come up with, particularly for human tests. So the assured criteria, and they're not bad criteria. So affordable, that's particularly true with the veterinary sector, I think, where price is very important. Sensitive, specific, minimum false positives, etc., minimum false negatives, user-friendly. It's got to be able to be used in the boot of a car, is what I'm kind of saying. Ideally, no cold chain. So ideally, that's not always easy. Equipment free, and we'll come to that because I think this is holding back the market, and easily delivered to end users. So these criteria have been around for a long time now, but I think they're good criteria, so something to think about. So advantages and disadvantages, I'll go through these very quickly. So quick turnaround time, obviously, maybe small volumes of samples, they're particularly good in remote areas. So I won't go through all of these. False positives and negatives is a real problem with point of care tests. So they've got to be sorted out. And lack of standardization, reference materials, that holds back both veterinary and human. That is a big problem. So we'll maybe come back to that as well. So for you guys, if you're going to put a point of care test into action, you really have to think very carefully about, is it worth doing? What is the pathology? What are the characteristics in the endemic areas? What about the biomarker of interest? There are relatively few biomarkers out there, very difficult to make sure that they're not false positives or negatives with them. And this is a big one, the type of patient sample. If it's fluid, in general, that's very easy to deal with. If it's tissue, that's really hard to deal with a lot of the time. And I'll come back to that. And what does your readout mean? What does it mean? So early on in disease, late on in disease, etc. And what are you going to do with those results? If you're not going to do anything with those results, then you are absolutely wasting your time. There's no point doing it. So there's a whole lot in there. And this is another one, is portability. What do we mean by point of care? And this is another one, as I will detail, is holding back the market. It's very easy to have something the size of a phone or a lateral flow device, no problem at all. But if it's kind of this size, can you use that in the boot of your car? Maybe. How expensive is that? Is it a cassette type arrangement? You can put something in. And that is a difficult one. And I will say a little bit about that later. And I think personally that is holding back the point of care market in both humans and the veterinary fields. Okay, so I'm quickly going to go through some of the devices that are out there and what's going to hit us in 5 to 10 years' time. And split this into two, so that's protein and nucleic acid. So let's look at some of the protein tests. So lateral flow and paper-based. So lateral flow tests, I'm pretty certain will be familiar to all of you. This is an example here from a company, in fact, influenza A and B in China, so producing these tests. There are some ones in Europe as well. This is 4 pigs, they're marketed 4 pigs. So you have, in this case, influenza virus comes in, immunogold particles or antibodies, runs down a strip, and then you have anti-influenza A and B, and your control line, which is secondary antibodies, very straightforward, and you get one band, or influenza A, influenza B, or a negative result where you have your control. Very straightforward, relatively easy to make, actually. You can buy kits now to just do your lateral flow test. Very straightforward. So here's one that's a bit more recent. This is to do with African swine fever. So on this side, you've got, here's the blood. This antibody here is against VP72, which is on the viral. This is a monoclonal antibody. It works really well. And on this side, you can see here that the detection limit of the, for at VP72 is similar by lateral flow and ELISA. And this is a really big point now. 5 years ago, the mantra was, if it could be measured by ELISA, standard ELISA, that would probably be good enough for a lateral flow. Well, nowadays, that's certainly true, but because nanotechnology is coming along, you can actually have lateral flow devices which are exquisitely sensitive. So the whole field is changing there. That mantra no longer applies. But if you're in this game, it's certainly a good starting point, without a doubt. Yeah. So this one here, not on the market, but has been used to look at the ASF sweeping across Europe, as I'm sure this audience is well aware, and we will hear more over the next 2 days at the conference. So a quick kind of look at the advantages and disadvantages of lateral flow. Short development time, in general, a long shelf life, that's good. Don't normally need pre-treatment. You can usually use blood with lateral flows, that's very good. And you can detect protein and nucleic acids, and I'll show you an example later with nucleic acids. So what are the disadvantages? You absolutely need a good antibody. If you do not have a good, ideally monoclonal, you're going to get nowhere. Polyclonals are not very good with lateral flows. Monoclonals are the way forward. And there's a big one here. Oops, go back one. Pre-treatment required for non-fluid samples. If you have lung, brain, etc., that's really difficult. You're going to end up with some pre-treatment, and that is really hard. And that holds back lateral flows in general, is with samples. And there's this one down here as well, so qualitative or semi-quantitative. Most lateral flows are qualitative. You can make them quantitative, semi-quantitative, but most are qualitative. But that might be all right. Yes or no, is that pathogen there? If that's good enough for your clinical diagnosis, no problem at all, proceed. If you want something a bit more than that, so the amount of virus, for example, that's present, that's different. Lateral flow may not be the right thing. And it's really holding back the market, actually, with lateral flows, is this qualitative versus quantitative. So I was looking at a review the other day. So qualitative, visual inspection of colors. You can't see this, I can't see this either. Over the far side, semi-quantitative, you might have some ladders. Quantitative, a machine. And it's the machine that is really holding back the market. Now, I had a look at a review the other day, and who were people developing in this area. And they were talking about machines which were in the order of 1,000 to 24,000 euros. That is not going to be bought by people, I don't think. That's just too much. So that's awkward. But as I've said, do you need quantification? I would argue with a lateral flow, and mainly the protein ones, you probably don't if you're going to do a point of care. Multiplexing is more difficult, without a doubt, with lateral flow. Very difficult, but there are simple ones, 2 or 3 out there. If you want 5 proteins, then that starts to become really difficult. However, again, things are moving on. Here's a very simple one on this side, so malaria, where you've got parallel lateral flows. That works quite nicely. And this is a paper now a couple of years ago, where basically they put lateral flows in this wheel shape arrangement. And so you put your sample in the middle, and you can then look at, in this case, 10 different bacterial pathogens. So that is that's a really nice example how you can go from relatively simple and then look at a whole load of pathogens. So I think we're going to see more of these guys over here coming onto the market. That is simple and it works to treat. Okay, so I said about machines. Well, the way it's going is now you have a handheld thing, you put your lateral flow in, and it can measure whatever the line is and the intensity. So there's lots of companies out here doing this. So in 3 or 4 years' time, I think this will be actually fairly standard. And this is cheap. So we'll see how that develops. And the future is paper. That's the way it's going. So there are already research, well, not products, but research being done so that you can have layers of paper, and if you arrange it right, you can have those paper. It's like microfluidics, so you can do immunoassays, etc. And probably can't see it on this one. They already exist. They've been around for 5 or 6 years. There's no product at the moment, but this is the future. And why is this the future? Boy, it's cheap. Yeah, so if you're talking about a few cents in this case per product, and most of your cost is coming from antibodies, I think we're going to see these being developed. They're not quite there yet, but they're certainly on their way, and I anticipate seeing a lot more of these. So I think that's definitely one for the future. Okay, so I'm quickly going to go through nucleic acid-based tests now, and then we'll move on to our own work. So you guys will be familiar with this, qRT-PCR, etc. tests. They are commercially available, widely used, and I'm pretty certain most people in this room have applied those tests to those. So what about point-of-care tests? Well, there are so few of them that are nucleic acid-based. I don't know of any on the market, but they have been widely used for research purposes. And they're based on isothermal amplification. So and this is 2 examples, loop-mediated isothermal amplification and recombinase polymerase amplification. So the idea is that you can produce a lot of nucleic acid by essentially PCR-type techniques within half an hour with these guys. They run at different temperatures. So LAMP runs at 60 to 65, and RPA runs at room temperature. So if you can get a lot of DNA very quickly, in half an hour or so, now you have a chance to have a point-of-care test. So that's LAMP and RPA, and you can look at the websites to see how these are done. So what about nucleic acid tests? Are they going to hit the market eventually? So the strengths, high discriminatory power, you can multiplex a range of pathogens, so that's quite good. Not affected by antibiotic treatment, it's nucleic acid. And the data is easily shared. The data is sequence, etc., or amplification, very easy to share. The opportunities, this is considered a growth area for the veterinary sector. It's a massive growth area in the human sector, lots of examples. One you see a lot is that for the veterinary sector, there's less regulations to apply, so you can get something out there. So that's quite good. Loads of sequences becoming available, I mean loads, so you can adjust your test as you go along. Weaknesses, false positives, false negatives. Just because DNA or RNA is there, that doesn't necessarily mean it's involved in infection. So that's not quite so good. Threats, low cost in the veterinary sector. And this is what I'm going to ask for you guys maybe later. Conservative sector. The human sector will move forward very quickly. So this not quite so much. Okay, so I'm going to quickly go through these. These are LAMP and RPA. You can detect by turbidity, fluorescence, lateral flow. No problem whatsoever. What's holding back the market? Machines. Again, very expensive. They want this to be accurate. That is what's holding back the market. This is for research purposes only. You see that all the way along, and that is the problem. So really no different to lateral flow. The future, so this is one you can go and have a look at. This is Sherlock. So specific high sensitivity enzymatic reporter unlocking Sherlock. And the idea behind this one is you use CAS technology and simply molecules which come along, recognize a sequence, have a reporter on, and you can detect this very quickly. This is from a paper last week. This is very simple, can be applied to any pathogen. We're going to see products from this in 2 years' time. This comes from the University of Berkeley. This is going to happen. This is another one with the future. So this looks a complicated slide. This is actually from my colleague at Imperial. So basically you can have a chip. You can use LAMP amplification to get lots of DNA, and you can detect whether you get a signal by pH changes. Very, very simple with these ESPHM receptors. And these things are about this big. Yeah, they're very small, essentially. And the way it works is very simple. You have a base added on in your PCR reaction, in your LAMP. You get a signal, pH change. Thank you very much. That's it. It's very, very simple. And the idea is eventually you have your sample and you have a microfluidics device, a microchip, and you can detect everything in one go. One simple device. So this kind of exists in the laboratory already. This is eDNA. You can buy this, very expensive. You have cassettes. That is for sepsis. That company exists. And this is the future here. Already exists for Zika and dengue. You can just have a little chip, put it in, and away you go. So that is the future. As I said previously, what's holding it all back is very straightforward, easy to do with lung samples, etc. Sorry, not easy to do with lung samples. Fluids, no problem. Tissue, bit of a nightmare. So that is what is holding the market back. Okay, so I'm going to change tack. I'm acutely aware of the time here, to some of the work that we've been doing and towards a point-of-care test with pathogens. So the guys that we're interested in are these. Be very familiar with this organism, APP, Parasuis, Mycoplasma, high ammonia, Streptosuis, and Multocida. So we've been involved in a big study where we've taken pigs which have come actually post-mortem for APP, Parasuis, and Streptosuis. No question that these are involved in the diagnosis. So that's one arm. The other arm is where you have pigs that have come in. They don't have these pathogens, and they've died for some other reason. So we've swabbed the trachea and the bronchia for APP, Parasuis, and grown them up. So two arms. So the idea behind that is that you can have species-specific genes from the whole genome sequencing, serotyping, I'll talk about APP, but not any of the others, and pathotyping. Do you have strains which are not associated with disease? And the answer to that is with Parasuis and Streptosuis, absolutely yes. So that is pathotyping. And so what we've done is come up with a series of multiplex PCRs, and I will talk about the species-specific ones and also the serotype for APP. So essentially what we did was we had 200 genomes each of APP, Streptosuis, and Haemophilus parasuis, and 120 from Mycoplasma pneumoniae. Multocida came in later. We're using published primers for Multocida. And we looked to find out what were the species-specific genes. And we designed primers to generate 2 amplicons per species. That was done deliberately, so that if there was one of the primers didn't work, because we didn't have enough genome sequences, then we had a backup. Our main problem was Streptosuis, and the so-called divergent Streptosuis. So this is a paper from our consortium. This is whole genome sequences. And you can see here, on this side, you can see lots of sequences the same, just look at the colors. But there's a very small subsection of strep suis, which is different. And that is the divergent strep suis. And the problem for us was that they were virulent. So it was very hard to design primers. And Janine, who's in the room, drove her completely nuts to find primers for the divergent strep suis. That was really awkward. But in the end, we came up with a multiplex PCR, which is this one here. So you APP, parasuis, etc., and the divergent strep suis. So we've extensively used this on lung samples, all sorts of fluids as well, and this works really well. And if you don't believe me, ask our UK Ceva colleagues, who will, I'm sure, back that statement up. This works really nicely. An example is here. So here we have some pigs which have come in for various diseases. Here was what was isolated, and then what we found by PCR. So pretty much isolation and PCR correlates. If you look at pig 74 in the last column, in fact, by PCR, we picked up Multocida, which was not picked up by culture. And we have quite a few examples of this. So it seems to be quite sensitive, and it seems to work quite well. We've also tried it on oral fluids. So it works quite well with parasuis, Multocida, and strep suis. Doesn't work so well with APP or hyonomyniae, but that's kind of fits a little bit with the literature. Some people say it works okay with APP, so I think the literature is mixed on that, but it works quite nicely. So the question for us, I guess, is where we go next with this. And I think personally, and we'll ask for feedback from, appreciate feedback, that we think this one is one where you could take it forward to a point of care. Now, whatever system we're going to use, I have absolutely no idea. We'll work that out later. But I think that this is something that could be taken forward. And we'd appreciate some feedback on that one. Okay, how am I doing for time? Okay. Okay, so point of care test for APP, how relevant? Herd surveillance, used by a lot of people, LPS-based ELISAs, only gives you serogroups. Is that worth it with point of care? I would argue no, but if you think differently, then come to me. The APX4 ELISA, I don't know of any point of care based on that. It is an incredibly expensive ELISA for some of those that have used it. That may or may not be okay for a point of care. So I'm not so sure about that one. And serotyping, so there's the immunological-based methods, which also suffer from cross-reactivity, 1, 9, 11, etc. Forward, 4, 7, etc. So not so good. So I'm now going to talk about the nucleic acid-based methods and bring you up to date with serotyping in APP. Okay, so the starting point for this is a PCR which we came up with many years ago now, which picks up 1 to 3, 5 to 8, 10, and 12. The reason for formulating this PCR is, or was, that it covers all the UK serovars. So we were very UK-centric, and we're not going to apologize for that. But we were asked by lots of people, please can you make it into all of the serovars, which was 15 known at the time. And so our first thought was to do this, extend our published PCR to include 4, 9, 11, and 15, which were known at the time. Fair enough. And then have a second PCR to cover 13 and 14, which are also BioVar2 classically, so NAD independent. And then, so that was our first thought. So we got a whole load of new genomes. And when we did that, this is a population map of all our strains all the way around. What we noticed was, actually, based on the capsule locus, there are probably a serovar 17 and a serovar 18. So there were new serovars out there. And so this was very useful. So based on the capsule loci, which you can put into 4 different types, arbitrary, 1, 2, 3, 4, You can design primers, i.e., I've got one down here. This is for 16, actually. I'll talk about that in a moment, which are very specific for each capsular type, and give you the Ceva. So when we started this, then there was a publication from Rita Sarkozy and her colleagues in Hungary, and they reported, based on serology alone, that there was a Ceva 16. So we collaborated with Rita and Laszlo, and we did a whole genome sequencing, and indeed, the Ceva 16, absolutely unequivocal, is quite different to any of the others. So we've also included that in our multiplex PCR. So that is now published, that's one up here, and the 17 and 18 came out a couple of months ago. So there are now 18. And this is an example of the PCR. This is the Ceva 16 from the paper. You've got APX4 here, specific to APP. That tells us it's APP, and it tells us our reaction is working. And you can see that there's a very specific band that we have here, and again with the Ceva 17 and 18 separating out. So this works really nicely as well. So this is our current strategy for serotyping APP. 1, 12, and 15 plus APX4. If that is got an APX4 band but nothing else, we will then take it on to our second PCR, which will also confirm the biovar. Is the NADV gene present? And if it is, that confirms that it's a biovar. So does this work? Answer, yes. So here is the first PCR. So here's our APX4, and we have bands here except for 13 and 14. So this works really nicely. You just put it straight in, and away you go. And this is our second PCR. So we've been sent quite a few difficult strains, is what I would say, unusual strains. So these are ones from Canada, Spain, Canada, Denmark. And here's our NADV band here. So that tells you that it's confirms the biovar. So this one down here, you can't see it very well, is Ceva 18. This one is Ceva 17. So this it's allowed us to get a handle on unusual strains, is what I would say. So you've got Ceva 2, and now Ceva 2, and with NAV. So that's unusual as well, biovar 2. This works really well. So and we have got some
which do not fit into this either. So we suspect there are more Cevas out there.
So we've successfully come up with multiplex PCR. Do we need a point of care test for herd surveillance? Arguably yes, but that may have to be protein-based. APX4 is our best at the moment. I'm just not sure about that one personally. Serotyping, I don't think so. I think once you've got it in the lab, actually this does work off clinical tissues as well. So you could do it that way if you were just interested in APP. So to sum up, what I've been kind of saying, I've thrown a lot at you. This is a rapidly evolving field. I mean, a really rapidly evolving field. There is an expectation in the veterinary sector that there are going to be products on the market, and I think that will happen. A lot of companies now buying up smaller companies, actually, so the expectation is that will go through. I think there is a potential for the pig sector here. It will depend on cost. All of those things I talked about earlier will be all part of this, but I think it's there. I really can't comment on whether you guys are very conservative. You can tell me afterwards whether you are or not, whether you would use them. But I think personally that there is an opportunity for a lot of people to take things forward. So I'm going to stop there. I've got to thank a lot of people here. It was a big consortium which came up with the work that I described. So Janine, who's in the audience, and Jan Wynn in particular, did most of the work here. Andrew Rycroft at the Vet College, Brendan Wren, London School, Matt Holden at the Sanger, who did a lot of the sequencing. Marcello will be known to a lot of people in this room. He's long collaboration, Oyston as well, at the Serum Institute in Copenhagen, Rita, Laszlo, all our colleagues at Cambridge. This was a massive consortium, and Susanna will be known to many in the room as well, who was involved in the collection, organized the collection of the strains for the whole genome sequencing. And thank you very much for your attention.